All.Can International, as well as the Executive Director of the World Bladder Cancer Patient Coalition. And although we would have loved to have an opportunity to meet in person for the All.Can Global Summit, we are thrilled to have over 350 attendees with us today from all over the world, including All.Can International members and national initiatives. And it is really warming to see the interest and commitment from the community to driving efficiency in cancer care across the world. If we could have another slide, please. And our agenda today is a little over 2 hours, and it is focusing the discussion on two parts. First, we will reaffirm the case for efficiency with the first session on efficiency across the cancer care continuum, led by Dr. Vivek Muthu. And the second slide, please. Followed by the second session on harnessing data for better cancer care, led by Dr. Suzanne Wade, where we launch and present the new All.Can policy report on data. We will have an opportunity for a Q&A session with an audience, for which the session moderators will explain in more detail when the time comes. Next slide, please. And a few housekeeping rules I would like to share with you just before we begin. All the participants are muted throughout the entire summit. However, you are welcome and are encouraged to share your questions to the panelists via the Q&A button at the bottom of your screen. This webinar is also being recorded and streamed directly on the All.Can YouTube channel, so you can share the link with the friends and colleagues who may have missed the registration. And of course, the event hashtag is All.Can Global Summit, and I invite you to join the conversation with us, the attendees and the community on Twitter using this hashtag, and you may also tag All.Can Group along there. Next slide, please. So many of you today are familiar with All.Can, but at the same time, I'm sure we have many participants who may not be as familiar. So I would like to start with an introduction to All.Can and tell you a bit more of a story of how it all began and ethos behind the mission and the direction of All.Can. All.Can was originally established towards the end of 2016 as a coalition of multidisciplinary, like-minded profit and non-profit organizations and individuals. And All.Can set out on a mission to find solutions to the challenge of waste in cancer care. All.Can aims to identify these inefficiencies and focusing its work on improving efficiency in cancer care and leading to better patient outcomes and better allocation of available resources. Next slide, please. And I think All.Can is best described as a journey from an identified need and an idea to a tangible platform with committed multi-stakeholder participation and evidence-based to drive change, to drive efficiency in cancer care. And we looked at the impact of cancer on a personal level, but also on societal and microeconomic level, really aiming to build a better understanding of how to address it and make an impactful change for cancer patients, but also for society. It is estimated that around 20% of spending is currently wasted on ineffective interventions in our healthcare systems. And this waste and inefficiency, apart from the impact on our healthcare systems, also represents considerable and mostly unnecessary burden and costs for patients and their families in terms of lost time, anxiety and fear, impact on quality of life, and financial burden. We recognized that in light of aging populations and increasing costs not matched by budgets, there was a threat to the quality of cancer care. And it was important to look at the value and at the efficiency of the system. So we set out to answer the question, how can we deliver high quality cancer care with better patient outcomes with the same resources and constraints that we face? And along the way, we have learned that these changes can often be simple, cost next to nothing, not always, but sometimes they do, and actually make savings to the systems and have tremendous impact on quality, experience, and outcomes for patients. And we have an excellent panel today to really talk about that notion of efficiency in cancer care. We saw that those current approaches to efficiency in healthcare overall were narrowed, siloed, and often also unmeasurable. So what All.Can wants to do is to ensure and protect the sustainability of cancer care by bringing different stakeholders together, bringing greater global focus on the topic and shape the policy landscape, and really drive together with concrete examples drive together towards efficient, sustainable care. Next slide, please. And so the AllCan was born with patient and family representatives, healthcare professionals, healthcare economists, politicians, and industry representatives who were and remain united in their belief that we can do better with the resources available in cancer care for the benefit of cancer patients today and tomorrow. And I'm so proud to say that we have had interest and commitment from different stakeholders from the very, very start of AllCan, and that these very members of AllCan remain actively involved with us today. Next slide, please. And there is also a great strength in our international community, as we have growing number of AllCan national initiatives with almost 20 established national chapters right now. And many of these have grown and established organically, pointing to a real global need for improving efficiency and delivering better cancer care for patients within those countries. And these AllCan national initiatives are not only inspired by the mission of AllCan overall, whilst driving policy discussions and bringing stakeholders together within their countries, we're also inspired by them, their commitment and innovative examples of practical solutions that can be shared and implemented across countries. The AllCan Efficiency Hub features a depository of real-world examples of innovative approaches to cancer care, which deliver high-quality, efficient cancer care whilst reducing waste in healthcare systems in those countries as well. Next slide, please. And these are the core elements that underpin everything we do at AllCan, recognizing the urgent need to improve cancer care by looking at defining efficiency and doing so from a perspective of patients and what matters most to them. There are opportunities as well to improve efficiency across the entire cancer care pathway. And we will hear from our speakers today how we can take those opportunities and really drive transformational change in healthcare systems. And there I'd like to stress again that by focusing on what matters to patients, we do not only deliver better care for patients, but it invariably leads to better use of resources and helps ensure sustainability of healthcare systems as well. And as I've mentioned already, AllCan recognized early on that the challenge of sustainable cancer care cannot be resolved by any stakeholder group alone. And I believe AllCan was one of the first, if not the first, multi-stakeholder initiative in cancer space, which had a broad group of representation, including policymakers from the very start, and which also had peer-reviewed publication delivered jointly. And next slide, please. And the AllCan policy paper and the peer-reviewed publication give the grounding for the AllCan initiative, as we have set out to create political and public engagement to implement these mechanisms, policies, and actions that will improve efficiency and outcomes for cancer patients in years to come. AllCan believes in generating evidence that helps define how to improve efficiency in cancer care and helps to secure commitment to meaningful change. And one of the things we've achieved with AllCan is an international patient survey. We saw the need to gain a better understanding of where patients perceive their care is not focused on what matters to them, and find practical ways to remedy any gaps. And we had nearly 4,000 patients and caregivers from more than 10 countries participating in the survey, which was the largest international survey of its kind, to our knowledge, at least. And the conversation about ensuring value in the way we deliver care was often not defined specifically from the patient and caregiver perspective. So the AllCan patient survey was designed with that purpose in mind. And we asked patients where they had encountered inefficiencies in their care and where efforts were most needed to improve efficiency. So we have identified 4 main opportunities to improve efficiency from patients' perspective. And if you haven't had the chance to read the patient survey report, I encourage you to do so, and you can find it on AllCan website. But today we would like to share with you a short video now, which explains the AllCan definition of efficiency and how we see the way forward of addressing that.
What is efficient cancer care? For AllCan, efficient cancer care delivers the best possible health outcomes using the human, financial, infrastructural, and technological resources available, with a focus on what really matters to patients and society. Today, 20% of all health expenditure is wasted on ineffective or inefficient practices. These are resources that should be channeled towards better use for improved patient outcomes. 2 years of life expectancy could be gained by reducing inefficiencies across healthcare systems. We need to improve cancer care efficiency because inefficiencies can lead to premature mortality, a reduced quality of life, financial and time losses for patients, and inequities between different groups in society. Inefficiencies also weaken health systems, making them less resilient, less adaptive, and less innovative, resulting in financial losses and missed opportunities for improvement. Also, inefficiencies can demoralize and frustrate care providers who feel unable to give optimal care to their patients. So, how can we achieve greater efficiency in cancer care? Let's start by putting the patient at the centre. The patient perspective is crucial to define health outcomes that matter, in line with the concept of value-based healthcare. We need to promote an evidence-based and data-driven learning system. Key outcomes and quality or performance indicators should be defined through multi-stakeholder collaboration, and data should be evaluated in terms of health outcomes achieved in relation to resources spent. We must invest in technology, adopting innovative diagnostics and digital tools that improve health outcomes by enabling coherent use of health data and by supporting care provision. We should break down silos. Efficiency is best achieved through a cross-silo approach that spans the entire health system. We should scale up good practices. Innovative and efficient cancer practices should be championed across the health system, while phasing out ineffective, duplicative, harmful and/or wasteful cancer interventions. We must support healthcare providers by giving them the opportunity to learn how to improve efficiency in cancer care. And throughout, we need to implement suitable legislative frameworks, policies, and incentives that foster efficiency in cancer care and promote better outcomes for cancer patients. Efficiency gains should be reinvested into efficient health systems and practices, and they should not be an incentive for cost containment and cutting. At All.Can, we believe inefficiencies need to be addressed across the entire cancer care continuum, from prevention to screening, diagnosis, treatment, and follow-up care, and at the levels of system, services, processes, and technology. Together, we all can.
So here is the definition of All.Can definition of efficiency in cancer care and the way we see forward of addressing the inefficiencies and bringing better cancer care to patients. We all have responsibility for and shared interest in improving efficiency in cancer care, and political will is an essential starting point for this change to begin. National governments, of course, must be at the helm as they are ultimately driving the decisions on the funding on allocation of resources. But of course, the European Union has an important role of coordination and leadership to play, and there couldn't be a better time for wider international collaboration in this sphere as well. And putting patients at the heart of everything we do, we were able to identify areas where patients see inefficiency in their care. And today we launch a policy report with a how can we use the data to reduce those inefficiencies. Recognizing the potential of greater efficiency in cancer care is simple, yet implementation, however, is more challenging. And I trust today's discussion will help us to get to the path to drive change together. So without further delay, for our first session, I would like to introduce Dr. Vivek Muthu, Managing Director at Marivek Healthcare Consulting, and a long-standing member of All.Can as well. Vivek's work focuses on healthcare systems, sustainability, value, and efficiency, and he holds non-executive and advisory positions in a number of healthcare companies and is involved in health policy initiatives focused on improving equity, sustainability, and efficiency of healthcare systems. So the floor is yours, Viv.
Thank you very much indeed, Alex. And yes, it's a great privilege to be facilitating this discussion, and it's fantastic to see how AllCan has evolved over the years to become something that is really driving change now and has got so much engagement. And thank you to all our delegates for joining us today. It was a great video that gave us a very good overview on what we mean when we talk about efficiency and why it's important. But this session now is to really delve more deeply into that. And we have as per our mission, we have a multi-stakeholder panel who I'll introduce shortly to discuss what efficiency means, why it's important from these different perspectives, and also most importantly, what can we realistically and pragmatically do to improve efficiency in cancer care. But before we move to the panel, I think I'm very grateful to Gregory Katz, who's Professor and Chair of Innovation at Value in Health at the Université de Paris, to give us a stimulus presentation, which is all around making the case for efficiency and its link towards transformational change and really improving outcomes for patients. So I'm going to hand over to you, Gregory, and then we'll come back to our panel. Thank you.
Yes. Can you hear me?
Yes, indeed, Gregory.
All right. This is my declaration of interest, and the funding sources have no role in the design of this presentation. The starting point of learning from efficiency or improving efficiency is to quantify the differences in hospital outcomes. And there are today tremendous variation. Take Belgium, rectal cancer. The mortality rate in Belgium varies by 700%, depending on which hospital is treating you, in Louvain or in Brussels. If you look at Germany for prostate cancer, severe incontinence after radical prostatectomy varies by 1,100%, depending on whether you're treated in Hamburg or in Berlin. And even for cataract, which is, let's say, a basic surgery, the capsular complication rate is 3,100%, depending on the clinic or the ophthalmologist who's treating. That's really shocking for a number of reasons. First, because there's just a handful of flags on this chart. What about France? What about Italy? What about Spain? Is it because the outcomes are so homogeneous that there's no inefficiencies, and this is probably why they are not featured on this chart? Or is it because they haven't even realized or started to benchmark patient outcomes? The second reason why it's shocking is that because the practitioners who underperform, the medical teams who underperform, will actually receive more money because they will reoperate, retreat the patients, and in a fee-for-service system, payments are driven by volume. So it's a way to incentivize failures in healthcare. Another shocking point is the fact that patients are kept in the dark. Nobody knows where to go in order to seek high-value care. This has to change. And this is why AllCan's conference today and commitment to improve efficiency is central. It's central also to assess the differences in views between practitioners and patients. Take again the case for prostate cancer. You can see on this chart, the red bars measure what doctors, what patients consider as most important in terms of outcomes, impotence, pain, fatigue. And you see in blue the differences and the discrepancies between physicians' perception for fatigue. It's not a relevant outcomes for doctors, but it's important to patients. So we also need to keep in mind that there's not a clear alignment between all stakeholders in terms of definition. The question today, when you start a consultation in oncology, is how do you feel? In the 21st century, it will be how much do you feel? The purpose is to quantify quality of life. And this makes a huge difference because if you quantify quality of life, then you can benchmark quality of life. But today we are completely lost in so many indicators. we need to establish a hierarchy of indicators. And for that purpose, the video we have seen, the definition of efficiency with clear concepts, with a clear hierarchy of indicators is central to improve value of care. Value and efficiency, value-based healthcare and efficient care are referring to the same equation, to the same ratio. Outcomes that matter most to patients related to the cost for the full cycle of care. The cost for the full episode of care, which includes different medical products such as devices and drugs. Now, let's be honest. The denominator is something, let's say, a black box or a blind spot for hospital administrators. Why? Because, well, we are dealing with billing costing systems based on pricing, based on billing, not really on cost analysis. The second reason why cost remains a blind spot for payers is because there's a clear reluctance from providers to share costs because they would expose themselves to tariff negotiations since, well, the tariffs are already public, but the costs remain today, a kind of industrial secret, and sharing this would probably expose to tariff negotiations. So this reluctance places the emphasis on the denominator, the outcomes. And the outcomes is the central element, the cornerstone of the value equation, the efficiency equation. This equation is different from lean management. It's different from HTA. It's different from cost containment. We need to clarify this distinction. Lean management is about streamlining processes. It's not about outcome and cost. Of course, it could be part of it, but you need to measure outcomes to make sure that the steps you will erase from the care pathway are not deteriorating patient outcomes. For that, outcome measurement is central. It's not also HTA. HTA is an approach that refers to outcomes and costs, but for a specific medical product, such as a device or a drug. Here, we embrace the entire care pathway. And it's not only cost containment, because we refer cost or we measure cost in relation to outcomes. There's also another element that needs to be clarified. PREMs and PROMs, they are not twin brothers. Usually we hear more and more this kind of confusion between PREMs and PROMs, and we cannot just mention PROMs without mentioning PREMs. This is, I think, a mistake. PREMs measure experience, such as comfort during a treatment or communication with caregivers. These are hospitality indicators, process measures. Whereas PROMs measure the end result of care, such as quality of life and functional recovery. They are not dealing at the same level. And there is here a confusion. Hospitality, hospitalization, of course, they probably have the same etymological root. Nevertheless, a good hotel is a place where you wish to come back. A good hospital is a place where you don't need to come back. So PROMs measure the success in healthcare. They are not patient experience per se. And of course, we can debate and discuss on this. Nobody's denying that experience is important. We are just trying to clarify what is the essence of efficiency and value in care. And of course, we are shifting from an obligation of means to an obligation of results because we are measuring outcomes and because we are entering the century of outcome-based payment. Now, there's another distinction that needs to be clarified if you want to change the system: outputs and quality of life. If you take classic indicators such as PSA levels, body mass index for obesity, visual acuity for cataracts, or glycemic control for diabetes, these are medical output reported by practitioners. Patient-reported outcome measures are what really matters to patients. Patients don't really care about PSA levels. They don't want to live the rest of their life with incontinence. Obese patients just want more autonomy in their daily activities. They don't care about body mass index. And the same for diabetic patients. Maybe their glycated hemoglobin is perfectly controlled, but they are so depressed and the quality of life is a pure nightmare because they are obsessed with that diet. So we need to really shift from medical outputs, which are important, nobody's denying this, and emphasize on patient-reported outcome measures, listen to patients, to indicators that patients consider as important in their daily activities. And actually, this refers to the WHO definition of health, which is not only physical outputs or physical indicators, but also mental and social well-being, which refer to outcomes. If you take breast cancer, you can see on this wheel that you have, of course, survival, overall survival or recurrence-free survival, but you have all indicators that actually refer to non-physical indicators, but more psychological or social indicators, such as depression, pain, or fatigue, body image, or health-related quality of life. So we need to have a broader vision of oncology treatment. And if you want to quantify the evolution of treatment or the value generated by treatment, for that, you need a scoring approach with metrics that measure through a standardized scorecard the difference between from scores after a treatment and before a treatment, or it could be also all the way the treatment and could be lifelong. So these measures are standardized, and you can quantify the health gain by measuring the difference between post and pre-scores measures, scores measures. There is also, and we will discuss this later today, a fantastic momentum to standardize outcome measures. This is driven by institutions such as the International Consortium for Health Outcome Measures, ICHOM, and also the OECD with the Paris Initiative, patient-reported indicator surveys. So you can see here all the ministries of health who committed to standardize outcome measurements in 2017. So that's also concrete reasons to be optimistic about this standardization and how to drive change and improve efficiency. There's also something absolutely essential to improve and change the system, is to make benchmarks transparent. You can see on this chart in the Netherlands, complication rate for rectal cancer. You have an auditor, DICA, and the auditor is measuring for each hospital the complication rate. The red bar is raising up. The groups themselves, after 4 years, the in-hospitality mortality rate decreases by 43% in 4 years only. How did they achieve that? Nothing else than mirror effect. You just show where each medical team is in terms of patient outcome and who are the leaders. So you can approach the leaders, detect them, identify them, get in touch with them, and enter into a peer-to-peer dialogue. So that's also the power of transparency. And you have a number of illustrations here, also in a hospital group in the Netherlands, something on where you can see here for breast cancer, the reoperation rate dropped by 27% after only 18 months through these open benchmarks across medical teams. So that's also really stunning, and there's tremendous room for improvement here. The open benchmarks are essential. It's a mirror to improve. It's not a static judgment. We are driving change through a dynamic of learning through iterative cycles. Plan, do, study, act, and these iterative cycles are actually beneficial on an individual basis, but also on a collective one, since you are leveraging the collective level within a medical community. For that, you need to embrace all the stakeholders, the practitioners, manufacturers, academia, health authorities, the patients, the users, the providers, and payers. Well, you also have medical teams. It could be hospitals, clinics, but it could be also ambulatory treatments, right? And most of the time, each medical team is, let's say, cornered in a siloed evaluation. You measure your performance without really measuring outcomes. And because those are not standardized measures, you cannot benchmark. The idea here to transform the system is to create open comparisons according to standards. And if you calibrate these instruments, if you define clear standards and stick to them, then a third party can audit the results, detect why medical team C delivers higher value compared to A and B, enable A and B to learn from C, and with these open benchmarks, share real-life data registries with all the stakeholders with two consequences. First, remuneration, second, reputation. Remuneration implies outcome-based payments. It's also the funding pillar of value-based procurement. Reputation is about patient referrals, reputation-based referrals, and that's also driving volumes, and volumes driving revenue. It's also a way to attract innovations and research grants. So that's also a competitive edge which drives the system. So the purpose here is to create this unified agenda around registries, outcome-based registries that will be audited. This is what we are trying to do in a big way in France, where we measure patient health gains with case mix adjustment and nominated benchmarks. We are also developing a fee for transparent outcomes, incentivizing practitioners to share health gains with patients, with payers, with peers. And this is a 30-euro fee per case. This is what Frontline is developing here with the Ministry of Health and the national payer. For that, you have a roadmap. We have published, my team has published with EIT Health, a body of the European Union, a roadmap for implementing an outcome-based registry, which is, again, the funding pillar of an efficient outcome-driven health system. And the key thing you need to do as a first step is detect who will be your third party, who will be the neutral facilitator auditing patient health gains in order to make sure that the data will not be biased. There will not be adverse selection of patients. In easy cases, you will define a case mix adjustment methodology to compare apples to apples. So my message is a call to clarify the definitions. In essence, it's just a way to standardize not only outcomes measures, but also the vocabulary we're using in order to drive high value care. Thank you.
Thank you very much, Gregory. I'm really grateful for that. Really great conceptual framework to define what we mean by terms like value, efficiency, outcomes, and cost. I think I also got why it's important and urgent to be dealing with this, why patients must be at the heart, why transparency is important, and why we must engage the multiple stakeholders that we have represented now on the panel. So that leads us very nicely into the panel session where we are going to hear from these multiple stakeholders. So I'm delighted to introduce Kathy Oliver, who's chair and founding co-director of the International Brain Tumor Alliance, Christabel Saunders, who is Research and Evidence Working Group co-chair and board member of All.Can International, and also professor of surgical oncology at the University of Western Australia, Nick Glazinga, who is head of healthcare quality of the Healthcare Quality Indicator Program at OECD, and Amadou Diarra, Senior Vice President of Global Policy and Government Affairs at BMS. So a cross-sectoral representation. And we're going to really now dig a bit deeper into really what is the case for efficiency, and what does it mean, and why is it important to these different participants in cancer care. Starting with the patient at the heart, so starting with you, Kathy, I think, you know, if someone coming new to this, they might think of efficiency as a sterile kind of word, and what relevance does it have from a patient perspective? And maybe from a patient perspective, you could tell us why it's important. Why does it really matter in a really critical way to patients, their carers, and then to broader society as well?
Well, thank you very much, Viv, and thank you to the organizers for inviting me here today. You know, I must admit that the concept of efficiency in healthcare was really not foremost in my mind when my 24-year-old son was diagnosed with a brain tumor in 2004. However, after my son died in 2011 and I became involved in All.Can, it actually struck me like a lightning bolt that in fact, efficient care was one of the crucial foundations of our family's cancer journey with our son. I mean, we were lucky because here in the UK, my son's cancer care was very good. He was assigned to a clinical nurse specialist in neuro-oncology who was super efficient at delivering all kinds of supportive care. He was also offered psychosocial care, one of the aspects of cancer care that is often sadly lacking. And he benefited from an integrated, highly efficient, multidisciplinary medical team. But we know that for many patients around the world, their cancer journeys are anything but efficient. Now, Alex talked a little bit about this in his introduction, but in 2018, All.Can conducted an international cancer patient and caregiver survey in over 10 countries. Nearly 4,000 people responded, as you've heard, making this survey, to our knowledge, the largest international survey specifically aimed at obtaining patients' perspectives on inefficiency in their cancer care. Now, our All.Can survey found significant gaps in value and inefficiency in cancer care. The gaps reported by cancer patients and their caregivers in our All.Can survey highlights really strongly what really matters to them and provides 4 key opportunities for improved efficiency in healthcare systems. So first, we must have a swift, accurate, and appropriately delivered diagnosis. Second, to improve information sharing, support, and shared decision-making. The third gap was to make integrated multidisciplinary care a reality for all cancer patients. And the fourth was to address the really significant financial impact of cancer on patients and their families. Now, to catalog some good practice examples of efficiency in cancer care from around the world, we set up the All.Can Efficiency Hub, which Alex also mentioned. And many of these examples are wonderfully pragmatic and really quite simple concepts, but they focus on aspects of living with cancer that are really important to patients and their families. Now, I love the Efficiency Hub at All.Can because it highlights scientific and medical advances which use both practicality and creativity to arrive at efficient solutions for various aspects of cancer care. And let me give you just a few quick examples. The PROCHE program in Paris improved the chemotherapy process for patients by phoning them in advance of appointments and assessing their side effects from treatment, then adjusting treatment plans before patients arrive for their next appointment. And this simple procedure shortened hospital appointments, reduced drug wastage, improved patient symptoms, and reduced healthcare costs. Another great example from the All.Can Efficiency Hub are MRI machines, which have been painted in various adventure themes, such as pirate ships or submarines, so that these otherwise really scary machines are much more child-friendly. And this has resulted in fewer children needing sedation, greater throughput for imaging services, and higher patient satisfaction. And a new app, which I've just discovered, has also been developed to help patients find their way to appointments in the labyrinth of long hallways and numerous offices in a major London hospital. The app is anticipated to reduce a patient's chances of getting lost in the hospital by 90% and decrease missed appointments by 30%. It also aims to reduce staff frustration at taking valuable time to give directions, and the app lessens the anxiety of patients and visitors trying to find their way. So this good practice isn't yet on the All.Can Efficiency Hub, but hopefully after today it will be. Finally, the COVID-19 pandemic has also prompted us to look at more efficient ways of supporting cancer patients in order to reduce their risk of virus infection, such as the use of telehealth and direct delivery of chemotherapy to people's homes. I just want to finish by saying that innovation to improve efficiency in healthcare doesn't need to be expensive either. Like the paperfuge created by Manu Prakash's lab at Stanford University. Now, this paperfuge is a hand-powered centrifuge made of paper, string, and plastic that spins biological samples at up to 125,000 revolutions per minute, enough to separate plasma from a blood sample in 90 seconds. And it costs just 20 cents. This demonstrates to me that affordable and powerful equipment can have a profound effect on efficiency, especially in countries around the world where access to financial resources and electrical power may not be highly available. So back to you, Viv.
Thank you, Kathy. I mean, that's great. I think you've underlined how ultimately it's about outcomes, and improving outcomes doesn't necessarily mean spending a lot of money. It's doing things in a way that actually benefits patients and is informed by what patients actually want. I want to turn to you. Oh, sorry, a little shout out. If anyone wants to ask questions, please go ahead and put it in the Q&A box. We are short on time, inevitably. There's so much to discuss, but we will try to weave that into our discussion. So please post away and we'll try and weave it in. Now, Christabel, let me come to you. I guess you are representing the healthcare professional and the provider perspective on this. And can I ask you, why do you see efficiency as being important? And to what extent do you sense that providers and healthcare professionals are thinking about efficiency as we define it here in AllCan when they design and deliver services?
Well, I think we do think about it, but the hard thing has been having the levers to actually make it work. We have such a disparate and siloed system, and working together has been difficult. And I was very pleased to hear Professor Katz talking about some of those levers to possibly make us have more efficient clinical services. And I could synthesize those levers into two things, I think: data and accountability. And those are going to be the two things that, if we can get those right, hopefully we as clinicians can, along with patients, and that's so important to co-design things with patients, start to look at how we can design more efficient cancer services. I put a little bit of thought today into how, as a clinician and as a researcher in this area, we find some of the problems and perhaps some of the solutions to develop a more efficient service. And I think one very important thing that we do need to think about is the entire patient journey along the continuum. We often, as clinicians, work in our own craft groups, and although we work often within multidisciplinary teams, we're not very good at offering that joined up patient care along the journey. So if we are going to design a service, I think it's really important that we try to start from perhaps right back at general practice and diagnosis. We think about some of the diagnostic imaging and pathology services that are so important to modern cancer care, as well as those acute treatments that we all know about: surgery, chemotherapy, radiation therapy, and then really important for patients. And we heard this so much from the All.Can survey: the supportive care, the psychological care, and indeed the care after acute treatment, really getting a patient to not only survive but thrive and get back to whatever their new normal is, and regain what's important to them in life, whatever gives them the joy in life. So asking the questions of patients, what's important, looking at the entire service from start to finish, so we can really try to look at, one, having great outcomes, but also looking at where we can increase efficiencies along that patient journey. Having the ability to do that, though, as I said, the crucial things are to have good data, which we simply don't have yet. So I'm delighted we're going to talk later about the launch of the All.Can data paper, which I think will talk a lot to that, but also ensuring that we know the outcomes of what we're doing and we have accountability for those. Thanks, Viv.
Thank you, Christabel. I mean, there's much you've raised there, I think, about the transparent, well, first of all, having the data, but also making it transparent so that it can be used to good effect. But also, I think you've touched on an issue about the siloing and the fragmentation that happens across the care pathway, which often is a really important barrier. And it's one of the things that we call out in AllCan. And maybe that's something we can come back to, is how that gets overcome across a service. But before we do that, let's go back to the issue of you raised outcomes, Christabel. So I'm going to ask Nick, who is involved in the Healthcare Quality Indicator Program, which I guess is about identifying those outcomes and making those transparent. So maybe you could tell us a little bit about that program and how is it relating to efficiency and leading to, or how do you hope it will lead to better and more equitable cancer care?
Happy to, and thanks for inviting me as a representative of the Organization for Economic Cooperation and Development. Perhaps I should explain a little bit of what efficiency means from an international economic organization. In essence, we are working on supporting countries in creating wealth and creating well-being. An important part of well-being is health. So we try to capture the investments in healthcare, and that runs up to 10% of many of the OECD member states, 10% of their gross national products, and health. But to really capture how did this spending on healthcare as part of our economies contributes to populations realizing their potential health, we need far more information on quality and outcomes. That's where the Healthcare Quality and Outcome Program comes in, started in 2003. So we collect a lot of intelligence on quality and outcome measures. Now, specifically for cancer, I want to articulate three things. First, how long do you take the continuum for looking at cancer and cancer care? For the OECD, that doesn't start with the diagnosis. It basically starts with first looking at the risk factors in a country, smoking, air pollution, obesity. It looks at the existence of evidence-based screening programs and the participation in those programs. It looks at the stage of diagnosing and trying to find out at what stage of the cancer is it diagnosed. And luckily enough, working with the Concord study, international cancer registries, we have for more and more cancers, also the data from countries of what is the percentage of an early and a late stage of recognizing the cancer. And then we start looking at the rest of the trajectory of the treatments, the follow-up periods. And actually, one of the few indicators we have there that is internationally comparable is the 5-year survival rates, although we do work on readmissions and complication rates. But we take that whole trajectory, and that was the basis of the first report on cancer care in 2015. We continue doing that, but we see, my second point, the problem with the data. And data has also to do with linking data. We have different types here in the cancer field. We have registry data, we have administrative data, we have very important what is in the electronic health record, but can it be linked to the record in primary care and in long-term care? And surely also important, the patient portals and the patient-owned data themselves. So the OECD is involved in many discussions on the further improvement of the data infrastructure in member states to really link this data, partly for creating knowledge to improve the effectiveness of care, on the other hand, to really streamline the efficiency of the care trajectories. And the third point I want to make is the emphasis on person-centeredness. I was very happy that Gregory Katz mentioned the Paris program. Since 2017, the OECD got the mandate from the Ministers of Health to work on person-centered outcomes. That means we do a lot of work on PREMS and PROMS in the Paris initiative. But the essence there is to get countries to start measuring the patient-reported outcomes, because we don't want to steer everything just on avoiding mortality, the death. We really want to have other valuable outcome measures that tell us about the value that is created through cancer care. We have a program now already 4 years in breast cancer. It's produced data in 2019, and this year in Health at a Glance in November, we will again, with around 15 groups of centers, have the PROMS data on the breast queue. But far more important is that in the whole field of cancer care, this becomes part and parcel of cancer care, and it's used in the consulting room. It's part of the dialogue between the healthcare professional and the patients to really have a debate of what would be the added value of this care for me. Stop there for an introduction. I'm very happy with the AllCan initiatives and happy to see how, from the perspective of an OECD, we can align with the data collection that you are already doing and try to increase.
Thank you very much, Nick. Already coming through very clearly is this is happily, because that's the next session is going to be all about the data, and about the data report AllCan's launching. So I think that you really highlighted the importance of that, and the importance not only of looking at top level indicators like mortality. That's that's the very coarsest picture that we can get. It's really about what's important to the patient all along. Yeah, so thank you. We will come back to some of those points, I think, and I would like to ask now, Amadou, so you're coming from, so Gregory mentioned about how manufacturers, industry needs to be involved and be a stakeholder in this. Why does or should industry see efficiency as an important goal? So why should industry support initiatives like All.Can or the quality indicator program and so on?
So first of all, thank you, Vivek. It's a pleasure to see many familiar faces, and I also want to thank the organizers for inviting me. And having been one of the founding members of All.Can, I can only really be thankful and admirative of the outcomes, whether you look at All.Can International or what's going on at the level of chapters. I think to answer your question, we're all in this together, and the industry does not operate in a silo, as Professor Saunders mentioned. And so we are operating in a way that we have to take into account that we should all row in the same direction, whether we talk about prevention, whether we talk about diagnosis, if we look at the care and treatment aspects, or survivorship. And so Kathy Oliver mentioned the patient survey, which uncovered a lot of inefficiencies in terms of the time to diagnosis, but also the treatment options and all the inefficiencies that can result from there. And therefore, for our industry, it is really important to be part of that reflection, part of understanding how we can improve things from our perspective, how we can join hands with partners. One of the aspects which is really important is that efficiency underpins the sustainability of healthcare systems. And I think we had a brilliant presentation and also very interesting comments that highlighted the fact that without this sustainability, it's very difficult to actually focus on patient outcomes and societal outcomes in an effective way. And therefore, for our industry, it's really important to be associated not only via the research and development and the partnerships that we can have with all stakeholders, healthcare professionals, but also governments, and I have mentioned patients, of course, before, but also at large with the society. There is a say which is that health equals wealth, and therefore there's this virtuous loop that can be initiated and entertained by all stakeholders. Thank you.
Thank you very much, Amadou. I'm going to move now that we've already got some questions coming through, actually, which is great. I'm going to weave one of them into a question I wanted to ask anyway, which is this broader extension we have in our mission statement at the end, with a focus on what really matters to patients and society. That's how we're defining efficiency. So I think it's a question both for Kathy, but also I think for Nick, which is who it's been directed to. So Kathy, I think, what are the dimensions that beyond mortality that we need to be thinking about when we're talking about what's important to patients that define efficiency? And for Nick, I think even on the subject of mortality, I think we've got such good survival now in some cancers that we're extending survival to to a much longer period. Should we be looking at mortality and stretching that out, the actual outcome of mortality, not just 5-year mortality, but 10 or 15-year mortality? So even the indicators we've got, the hard-nosed clinical indicators, are they fit for purpose? So couple of questions there sort of woven into one, and anyone else who wants to chip in, please raise your hand and I can, from the panel, and I can bring you in as well. So Kathy, to you first.
Okay, well, just really briefly, what really matters most to patients? Obviously, survival is very, very important. Quality of life has been mentioned as well. Fewer, more tolerable side effects are important to patients with regard to their medications. And I think it's also important to mention that innovative care is crucial. And that often happens when we become collaborative and courageous and experimental. And some of the examples that I quoted in the Efficiency Hub address that. And of course, patients want more time. That is really of value to them. They don't want to be hanging around in hospitals all day waiting for a treatment. They really want efficient handling of time. And I also just really quickly want to say that what is meaningful and valuable to a patient is not something that's static. It can change throughout the patient journey. What a patient values when he's newly diagnosed is different from a patient who is approaching end of life. So it is a very complex question with lots of answers to it. And those are just a few examples of what really matters to patients. And of course, being listened to and communicating well with their healthcare professionals. That's also very important.
Thank you. And I think something you've pointed out before, I may add to that, is that you've actually pointed out that that's not opposed to necessarily what's good for or what's cost effective for the health system, because all those things, if they're done better, means fewer missed appointments, better adherence to treatments, more engagement with the health system, and better outcomes is very likely. Nick, the second part of the question, if I may, was really around even those indicators that we think are already well defined and already captured to some degree, like 5-year mortality or mortality. Are they fit for purpose, or do we need to be extending them? Because actually, as Kathy said, they're dynamic, and in some cases 5-year mortality is not a great indicator of good care anymore.
My answer would be, depends how global you're looking. So I surely wouldn't get rid of the 5-year survival rates, as long as I know that there are only 230 registries in the world, and there's still a large part of the world where they still have to debate to introduce a cancer registry. So if on a global level, I also see sufficient differences in 5-year survival rates. So over a longer period of time, and again, I'm thinking in countries. So over 20 years, I see that Eastern Europe has caught up with Western Europe. It's not similar, but especially if we're looking at the countries where for the big cancer types, it's saturating or very high level, it's obvious that you want to have additional information made to make that more actionable. And again, from a system perspective, that's why I was interested in the data that Professor Katz showed about hospital readmissions and complications. Because those type of outcomes are standardized and they are comparable within countries. I would not dare be that interested in aggregated complication rates, but basically see the spread within a country of the complication rates. We do a similar thing already in 30-day case fatality rate from myocardial infarction. So I know that some countries, the spread is much higher than in others. And when you compare that, you could actually do benchmarking, do mutual learning, and try to find out what is there in the cancer pathways in these countries that could improve. But foremost, the agenda of PROMs and PREMs and getting that implemented is an important one. And the OECD tries to push that. We do pilots, but not just to have international comparative data, but actually to stimulate groups, again, to pick this up and find out in breast cancer care that the measuring the breast Q before and after in clusters of hospitals in one setting is totally different than in clusters of hospitals everywhere. And then you hope that these networks start to communicate and start to build it into their processes. And my remark I made before, it only makes sense when you use it in a consulting room. So usually when I speak with the Erasmus Medical Center in Amsterdam, I'm based in the Netherlands, I'm involved in some of their cancer work. One of the big things we're studying, is this actually part and parcel of the shared decision making? Because if it's only used for aggregate information, then it beats the purpose. Value is created in the interaction between the patient and the healthcare provider. So that's where these exchanges should take place.
Okay, thank you. As ever, this discussion, we've got about 5 minutes left and the discussion is just beginning to kick off, but we've got the next session as well to explore some of what's been raised. I want to just ask two questions briefly of each of you. The first one is, from each of your perspectives, what would you say is a principal responsibility that you have, representing your stakeholder group, that you have? That would be one question. The second one is what we as AllCan, what an action that you would propose that we really need to do within AllCan, or you think would be worthwhile for us to carry the torch on. So let me ask the first one, and as I've got you, Nick, you know, an international institution that's driving policy and supporting more efficient care. What do you see as a principal responsibility that you have to engage here?
Well, basically what I explained, cancer is one of the largest burden of disease groups. So it merits attention because it takes resources which are not used for other things. So we see it as part of our mandates to look at the performance of countries in cancer care. And I gave you the way how we look at that. What AllCan can do is on two ends. On the one hand, I hope that we can share data and that you can enrich the very high level aggregate data we have to really understand the stories in countries, but also to help communicate to the broader community the importance of collecting and sharing these data. Because with some of the databases, it's not the technology of making it available, but it's sometimes the resistance of sharing. And for improved cancer care and learning, both via the artificial intelligence and pooling knowledge and experience to accelerate effectiveness, as well as for the efficiency of the care trajectories, these data are crucial.
Okay, well that'll be the subject of the next discussion, and hopefully that information will be working with you on that, I hope. Christabel, can I ask you from a healthcare provider and a clinician's perspective, what's the principal responsibilities you think for moving forward the agenda of efficiency, and what's something we could be doing within AllCan?
Yeah, well, I just wanted to touch on something which perhaps we haven't brought up so far, and that's looking at the equity of care. Yes. Most of us on this call, on this webinar, I guess may well be from developed Western European or other countries such as that. And you see around the world, of course, huge inequities, but also within our own countries. So it's all very well talking about collecting good outcomes for patients, but most of the outcome measures are only in the language of our own country, in this case, English in our country. So looking at populations that are disadvantaged, how we can improve the outcomes for them, but also trying to share some of the learnings that we have with countries that perhaps are not doing so well. And I'll just leave you with one story that really, I think for me, epitomizes some of the very perverse things that go on in cancer care. When I a few years ago, when we could travel, and I visited the Indian Cancer Congress and was visiting a local hospital, and they told me that a private hospital treating mostly patients with some degree of money, clearly it was a private hospital in India, that they had ratios of how each doctor had to order a certain number of PET scans each month. And so every patient that came through had PET scans for no good reason. I mean, that is incredibly inefficient care in a country which can certainly not afford it. So I think AllCan can be carry the banner for efficient care, not only in our own countries in the developed world, but also in the more developing countries.
Okay, that's great, because that actually speaks to a point that's been raised in the Q&A as well. And just to add to that point that's been raised, it's, you know, we as Gregory Katz said, we're not about cost containment, it's about efficient use of resources. So we don't stand at odds with trying to raise more resources as long as they're used efficiently, and certainly not in low and middle income countries. Thank you, Christabel. Amadou, can I come to you then? Yes, so the principal responsibilities of industry, you think, to engage with this, apart from supporting things like AllCan, thank you, and an action that we could be taking.
Yeah, so this is a very important question. And, you know, first and foremost, our industry needs to listen to the patients. And I think Kathy Oliver articulated very well, you know, the expected outcomes. And as she said, it's not a static, it's a continuous process. And so we need to listen and learn from the patients. I mentioned the survey, which was an enormous source of learning for us. But it is also about understanding better what the healthcare professionals are going through, what can make their experience and practice better. It's also speaking with policymakers and other key stakeholders. So in the end, it's not just about listening, it's also about coming up with solutions that address those needs. And it's both in terms of, efficacy, safety, but making sure that those outcomes that were very well described in the first presentation, sometimes the expectation can be different from the patient side and the healthcare professional side. So let's make sure that we address expectations. The other aspect is really to make sure that we contribute to sustainability of the healthcare system. So affordability is one of those elements. I think addressing also circumstances where we need to provide, these solutions. And it was mentioned about the developing world. So our industry is focusing on areas which are not the most affluent. But in the end, we need to co-create, we need to join hands, not just one stakeholder has the solution. And then when it comes to, the actions, things that I would say could be really immediate steps, I think the scale up, the sharing of information, making sure that, those informations are boiled down into policies that can change behaviors and ultimately make sure that the change is sustained. These are the immediate comments I have.
Thank you, Amadou. Thank you. So, Kathy, I'm going to come to you. We're pretty much out of time, so I'm sorry. I'm going to have to ask you to be brief. So, a principal responsibility and an action that we could be taking.
Okay, I think our principal responsibility is to make our voices heard clearly. It's a simple thought, and to also instigate discussion between all of the stakeholders in the cancer journey. Tell them about the terrible bits we've experienced in healthcare and the good bits, because both have benefits to build on, or things we can build on. I think too, we need to make sure that we communicate with academia, industry, policymakers, other patients, healthcare professionals, to get our needs across to them. And that's why I think as an action, what we should be doing at AllCan is, I'd love to see another patient survey now, 3 years after, well, nearly 4 years after we did the first one, especially in the post-COVID era, because things may change quite drastically. And I think we need to keep our fingers on the pulse and go out there and hear from the patients once again as to where they find inefficiency in their healthcare journeys.
Great, thank you for that recommendation. That's fantastic. So look, I'm really grateful. We're out of time now. So thank you, Gregory. Thank you, Kathy, Christabel, Nick, and Amadou. Really grateful for participating in this panel and for a really excellent discussion. I'm now going to hand over. I'm not sure whether I'm handing over straight to Alex. Yes, okay, and then we'll go on to the next session, which is all about data. Thank you, everyone. Thanks.
Thank you, Viv. Yeah, thank you, Viv, and thank you also, Dr. Katz and all the panelists. We've heard about some stark examples, really, of the impact of inefficiencies in cancer care, and but also some concrete actions for the way forward. And I can see some common ideas there as well. So we continue the conversation now with the second session on harnessing data for better cancer care. And I would like to introduce Dr. Suzanne Waite, Managing Director and co-founder of the Health Policy Partnership, and the importance of intersectoral and multidisciplinary collaboration to drive policy change has always been focal thread of her work. And Suzanne has been closely engaged with AllCan from the very early days of the initiative as well. So Suzanne, I give the floor to you.
Thank you very much, Alex. And it's really incredibly exciting to be here, and congratulations to everyone on this fantastic event. I think the previous speakers, all of them, in fact, have given the best sort of preface possible for the session that I'm going to be moderating this afternoon. But I just wanted to start very briefly by saying that, as has already been alluded to, this session will consist of a presentation first from Matt Hickey, whom I'll introduce in a sec, who's going to be talking about a really exciting report that I had the honor to take part in. And I wanted to acknowledge all the contributions from the AllCan data working group and our external advisory committee and the core researchers who made this report possible. And just to say that this report will be available on the AllCan website after this conference. So as of 5:30 today, CET. But also to say that I think the title is deliberate when we say harnessing data for better cancer care. Everyone has spoken about the need for data as an essential pillar conduit to drive better cancer care, be it at a systemic level, but also at the level of the individual person and patient. And I think what I'd like to try to get out of this session, and we'll have a panel discussion to try to get to this, is how do we actually harness that potential? We've seen the potential in many instances of data. We see it in incredible innovations, which are almost sci-fi like, and we see it in some very simple things as well, like just finding ways to cut down the silos and share data across providers. So without further ado, it's my great pleasure to introduce Matt Hickey. Matt is a senior radiotherapist by training, and he's also an entrepreneur with incredible insights into data and the use of data and artificial intelligence for predictive purposes and really data-driven commissioning. You can see all his various titles on his cover slide, and Matt is going to take you through the main findings and conclusions of the AllCan policy report on data. Matt, over to you.
Super, thank you very much, Suzanne. So it's an absolute pleasure to be able to present today the Harnessing Data for Better Cancer Care AllCan policy report findings. This has been a long time coming. And I can see Suzanne smiling in the amount of effort that's gone in from us and all of the different stakeholders that are involved in this. So I echo your thanks, Suzanne, to everybody who's contributed to this. So if we move to the next slide, please. Excellent, thank you. So the new report is fundamentally aimed at policymakers, where the intention is to, and care providers and decision makers, to provide a view on how we ensure that high quality health data, and I'll emphasize that, high quality healthcare data, are systemically collected and used to improve cancer care and patient outcomes, a theme that's been running through the whole of the talk today. And I echo what you're saying, Suzanne, about data is available. Is it good quality? And are we harnessing it for the right purposes? And we'll talk about those things as we go through. Next slide, please. So why this report? We can't really talk these days without talking about COVID, I think, because I certainly am not allowed to leave the country at the moment. I would have been in Perth for a presentation with Christabel this morning, and then presenting here today. So unfortunately, we can't get around the world quite so quickly. But COVID has done something rather fundamental to us in the healthcare sector with regard to focusing the world's attention on the potential role of data in addressing some of the biggest challenges in healthcare. And if it's done nothing else, really, it's shown that data holds a pivotal role in the way that we analyze healthcare services and the outcomes of those healthcare services. We've got COVID has resulted in a huge backlog of cases that will require greater focus in the future, and building on the AllCan processes of designing and evaluating efficiency and sustainable cancer care. This has been brought to the fore by COVID as well. And certainly in the UK, we've got, I think the last numbers were 5 million cancer screens have been missed, and a backlog of around 350,000 patients not going through diagnostic processes. So that's just two sets of data right there, which screams to us something that we need to act upon. And of course, as we move forward, the NHS has got a program called the Recovery Program. And of course, we need to recover from COVID as well. So digitization, a digitalization agenda is a key part of all of what we're trying to achieve here with regard to our post-COVID recovery plans. And I think we've got an opportunity to get this right. So a little bit of a reset, shall we say, in some instances, where we have the opportunity to address some of the long-standing hurdles and optimizing the role of data in driving health, high quality healthcare and efficient healthcare, and designing some of those measures, as Nick was talking about before, and ensuring they're implemented and the outcomes of those and the insights from them are shared across the ecosystem. Next slide, please. So again, I cannot thank the participants in the report enough. We don't have a lot of time for me to go through and thank each of the people on the slide personally. But you can see that we've got a huge representation from across different organisations and across the sector and across the world. So we couldn't have developed this report without the expert guidance from our advisory committee. So thank you very much. Next slide. So as the title of the slide states, the healthcare data system is complex. I wanted to show a slide that showed the ecosystem, the cancer data ecosystem, but it was so big I couldn't put it on the slide. It just wasn't going to be meaningful, and I think that's a little bit like getting too close to a planet. But I think what the themes here is that it's constantly evolving, and therein lies one of the issues, and also that health data is ill-defined. So the report focuses here on the different data challenges across the cancer care pathway, focusing on specifically on particular areas with regard to cancer registry data, and data from electronic health records and medical records, genomic data, and of course a theme that we've been talking about today, patient-generated health data, including PROMs and patient experience and patient-reported patient satisfaction. And of course, this goes right across the care continuum, from screening, diagnosis, treatment and care, follow-up and survivorship. Next slide, please. One of the big challenges that we also had was defining health data. So if we look at the Data Sage Lives 2020, we've used their presentation of or definition of health data, which is any data describing a person's health, their healthcare, or anything affecting any health issue or diseases they may have. This includes information created by health and care professionals, as well as information generated by patients themselves, from illness monitored through mobile applications and smart devices to screening tests and nutritional data. I think that starts to cover some of the spectrum that we work within the ecosystem with regard to a definition of health data. Next slide, please. So I mentioned about the healthcare data ecosystem. We're still far from harnessing the potential of data to transform cancer care. And we've got some fundamental and probably common challenges, certainly across the OECD countries. And I think none of these are insurmountable. So if we put our minds together and we use forums like this, then we can deal with some of these challenges. The first is inherent in the challenges inherent in data itself. The next is the challenges with the systems. The third, of course, is challenges embedding data into clinical practice and making sure timely, relevant insights are going back to the clinicians for decision support, and then drawing insights from the data. And that is all encompassed within the complexity of the data ecosystem itself. And that's a grossly oversimplified issue with regard, or a simplification of the harnessing data challenge that we've got. Next slide, please. Another challenge as we look through each of these a little bit closer is poor quality data and data not being representative of entire populations. And I know, Kathy, you mentioned something about this earlier on with inequity and bias and poor representation of maybe some of the rarer cancers, for example. And then the lack of the patient perspective. And I hasten to add here that the patient needs to be the center of everything we do. And yet it's concerning to see here that one of the challenges is getting the patient perspective brought to the fore. So what can policymakers do? The recommendations towards policymakers from our paper is to create national data quality standards. It's very important that the data quality is there to start with, and that this is regularly audited against the systems that are responsible for that are regularly audited with these measures. Demand greater equity in cancer research, and this was mentioned in the previous group as well. Ensuring representation of people of different races, ethnicities, sex, cancer types, and cancer data sets itself, so equity across the data sets also, and systematically collect data that are most relevant to patients, and use them to evaluate the healthcare system and provide a performance from the patient's perspective. Are they eliciting value from what's being delivered? Next slide, please. So with regard to the challenges associated with data systems, we've got limited interoperability in data sets. Certainly GDPR brings its own challenges, and we could go down a rabbit hole there. But ensuring that data is moved from one place to another or shared appropriately, or the insights from those data is shared. So jurisdictional challenges are a challenge, but it doesn't mean to say that we can't share the insights from our analysis that are happening locally. We've also got inconsistent use of data governance frameworks and low patient trust. And that's, I've been in another presentation yesterday that was brought to the fore as well, low patient trust and what we're going to do with the data. And I was asked a question this morning at another regarding insurance as to whether the insurers would use the data to look at risk associated with patients and exclude them from insurance. So that's an example of low patient trust. So what can policymakers do? Develop common data sets, specifications and processes for data collection, build harmonized data governance legislation and facilitate health data linking, sharing between providers, and use of national health codes of conduct. Again, very important to ensure that we've got governance around the data systems. Engage with patients and discuss how data are being used so that the trust can be built, and to address those misconceptions around nefarious use of health data. Constantly adapt legislation and tools to give citizens appropriate control over their health data so that they may act as their own gatekeepers. Another very interesting recommendation to the policymakers. Next slide, please. So with regard to embedding data and into clinical practice, further challenges that we've highlighted are limited actionability of data, poor integration of data insights into clinical decision-making. Christabel, you mentioned before about getting clinical decision support brought to the fore of the clinic, and high burden of data collection on care teams. And so the use of, we'll talk shortly about the use of AI and data collection systems. So what can policymakers do to support us with these challenges is build in positive incentives for data collection and the use of this data across the cancer care pathway, and foster a culture of value-based healthcare, where value is assessed by the perspectives of each of the stakeholders. Embed data analytic solutions into the care processes to enable rapid processing and feedback of data insights to the clinical team to enable and guide clinical decision making, and provide appropriate funding and resources to train, upskill the healthcare workforce so that they can keep pace with the innovations in the data collection and use. Next slide, please. So drawing insights from data, probably it's one thing to get the data, the quality data is another thing to be able to then use it. So poorly validated algorithms and inadequate analytical methodologies, another key area of challenge. And then there's the whole lack of trust in artificial intelligence. Suzanne and I have had a number of debates over this in our time. So what can policymakers do to support this area or this challenge? Fundamentally, we recommend the application of appropriate regulatory standards to protect citizen rights and values, and ensure that data sets from which insights are drawn are adequate, equitable, and sufficiently representative to train artificial intelligence algorithms while minimizing bias. That's a significant challenge. The analytics thereafter are used are standardized, are transparent, and subject to rigorous evaluations and validation of clinical safety and effectiveness. And I use the term observe, learn, optimize, repeat here for when we're referring to AI. And the insights drawn from the data are high quality and should be constantly evolving. Next slide. So what's our call to action with regard to this paper? We need to think of data as both an investment and an innovation. So appropriate investment needs to be brought in, and then we need to look at the innovations associated to enable us to harness that data. Having the correct data systems in place to be able to harness their value is as important to the future of cancer care as new medicines and other advances. And I'll just pause there to mention a chap called W. Edwards Dunning, who says, without data, you're just another person with an opinion. But I think what we've identified here in our policy is that it's not just to have data, it's high quality data and how you use that data to elicit meaningful outcomes for the stakeholders across the ecosystem. So what's the commitment we need from policymakers? To embed optimal use of data across all facets of cancer care in all settings for all cancer patients. So that's the challenge we're landing on the floor today. Next slide, please. Okay, thank you. That brings me to time.
Matt, thank you very much for doing a wonderful recap of 2 years of work in 20 minutes, which is no small task. I am now delighted to come to our panel discussion. And we're really delighted to have a very varied panel with us again in true AllCan style, representing different stakeholder groups. So please do feel free to ask your questions or make comments through the chat. We will be first, the way I would like to organize this panel discussion is first, I have some questions I want to ask to each of the members of the panel, and then we'll come to questions from the floor that I will look at through the chat. So first, let me introduce the members of our panel. Excuse me, we have Professor Deepak Kalra, who is the president of the European Institute for Innovation Through Health Data. Deepak has had many years of experience working on various aspects of data at the European level as well as internationally, and with a big focus, from what I gather, on governance and on the use of patient outcome data, amongst other things. Antonella Cardone is a board member of AllCan International, and she's also the director of the European Cancer Patient Coalition, which is the largest European umbrella group of patient organizations. And the or ECPC, as it's also known, has very interesting experience also, and has done a lot in the data space from the patient perspective. And then Abdullahi Sharif is Associate Vice President and the Global Leader for Affordability and Sustainable Access Solutions at MSD. And Sharif has been an advisor, I should say, on this report. So thank you, Sharif, for your always invaluable insights. And Sharif has really worked across different companies and also in consultancy previously and in academia. And as a physician, if I'm not mistaken, also really as an expert of trying to leverage solutions that are data driven to improve service delivery and cancer care. And then finally, last but certainly not least, we're delighted to have Dr. Roberta Ortiz, who is from the WHO and who is the lead of the Global Initiative for Childhood Cancer, and is also a pediatric oncologist by training, and has extensive experience really around the world of, again, trying to improve quality of cancer care. So a very illustrious, varied, and really exciting group of people whom I'm going to now ask some targeted questions to. So Deepak, if I can start with you. Yes. And thank you again for joining us. So Matt was tasked with summarizing, as I say, 2 years of research into 20 minutes. And I'm going to give you an even greater task, which is to summarize in about 3 minutes what you view as sort of the main, taking everything that, and taking everything from the data report, which I know you have read, but also with, where we are now in terms of the whole world of data and healthcare. What are the main priorities from your view for policymakers to sort of take this to the next level?
Okay, well, it is indeed, it's an even harder challenge than I thought, given the crisp and clear presentation that Matt gave, because the simple answer is listen again to Matt's presentation. But you've asked me to highlight a few things, top priorities. And with a view to policymakers, I'm really talking about people who will make policy level decisions that may include investments. And so I'm going to really focus on those elements of where I think we should. So it's my top 5, if you like. And out of the list that Matt gave you, my number 1 is actually investments in better data quality and the systems that enable better data quality capture. If we are going to seriously treat data as a resource that is empowering better quality care for all, then we still have rather poor, haphazard data quality. It's not really going to do us justice if we stay with where we are today. So that would be my number one. And I think that the reason I say investment is because people need to have enough time to enter data, rather than dashing a quick entry when they're making it. So that means people need training, people need to have enough protected time for record keeping. We need to treat record keeping seriously, and they need systems that are not administrative systems, but are really clinical, patient-centered systems. Number two is really to invest much more in the wider adoption of interoperability standards. We now have a mature enough standards landscape that even though it's not perfect, we could do a huge amount by just using everything that's already available. Even if we didn't advance the standards landscape at all, we have way underachievement of implementation and adoption. Why is this so important? It's because people with cancer can live a long time. They can have multiple diseases, not just cancer. Teams need to have joined up holistic views of an individual person. And today they still don't have that. And that means longer term perspectives, not just short, sharp data views, lifetime records. And number three is complementary to that. I think we need a lot more data and apps delivered to the patient's front door. Patients are important recipients of data. They have every right to understand what's going on and to be part of joint informed decision making. They need to be able to inform sometimes their caregivers about what's happening to them. And they can't do that if they don't have the data. But of course, patients need to be capturing data. And we've heard all through this conference so far the importance of outcomes. And I don't think it's acceptable that outcomes are collected on a paper form in the hospital bed. These need to be continuously tracked on a regular basis by giving people the tools so they can capture their outcomes. They can see how their outcomes are doing compared to other patients like them, so they can tell if they're on a good track or not on a good track. The fourth thing, I think, is we do need more investment in infrastructures and good governance models developed with active patient involvement in decision making as part of those governance models, so that we can use data more widely. The classical headline is research, where we know there are still many stumbling blocks to scaling up data use for research. But in fact, even for learning health systems and quality improvement, one comes across countries and situations where people are anxious about being able to share data between care organizations. We've got to break down those barriers. Yes, the GDPR must be respected. I'm not challenging that, but there's plenty of ways we can use privacy enhancing methods to share intelligence and really all learn much more from this good interoperable data that I've encouraged already in the previous points. And the final one is an investment in data literacy. Yes, of course, patients need to be data literate, but so actually do health professionals and some people in research. They need to understand better about the limitations of interpreting data of variable quality, about what interoperability standards are and what they can achieve, and of course, good data protection practices. So we need an empowered, educated workforce, including patients and their families and charities. We need a data ecosystem that delivers the vision that you have as AllCan. Okay, that's my story. I hope that's crisp enough and not too long.
I think we're going from strength to strength here in terms of crispness. So thank you very much, Deepak. That was extraordinarily articulate. And I think if people should listen to Matt's, I'm going to add them on now, the building blocks. They should listen to Matt's presentation again, and they should listen to your 5 points again, because really it was a fantastic summary. So thank you. And actually a great segue into my next question, which is to Antonella. And Antonella, as you know, as you know, an integral member of AllCan, we keep on focusing, and this point has been made several times today, that efficiency isn't just about focusing on the resources. It's you start focusing on what matters to patients and build the resource allocation and systems around that. And one of the, I should say, one of the sort of central tenets of building this data paper, also this policy report, was let's make sure we try to always look at the use of data and the optimization of the use of data in order to improve things for patients. It's not an investment in using data for data's sake or for research sake. It's really about improving things for patients. And then at the same time, there are the issues that you've just raised, Deepak, in terms of data literacy, potentially lack of patient trust in terms of understanding how data are being used, and an obligation, of course, for greater accountability and governance frameworks that protect patient privacy. So I was just wondering, from your perspective, how can we better sort of secure the support and trust of the patient community and of patients individually in this data-driven cancer environment? And are there any good examples that we can learn from?
So thanks, Suzanne, for inviting me to speak here, but also for this very interesting, very good question. So the data-driven revolution is transformed and is transforming and will transform healthcare services worldwide. It is not a thing of the future, but already a fact of the present and must be addressed properly. So digital health has an enormous potential that can significantly help and accelerate the shift towards a patient-centered healthcare in Europe. We have seen during the previous months with the response to COVID-19 pandemic, the relevance the data exchange has between countries and healthcare systems themselves. Here, for example, telemedicine plays an important role to provide better outcomes, and not only better outcomes, but also personalized medicine and tailored treatments to each patient in a sustainable healthcare system. So furthermore, innovations in the way we use and collect data and our ability to draw insights from data are the basis to improve efficiency at every stage of the care pathway, from screening to diagnosis to care and survivorship. So it is important to highlight that patient trust is key, and creating awareness is essential. So there is a need to develop tailored educational tools, as patients need to comprehend the value of the power that data have for managing cancer care and provide the best outcomes. To build trust, patients' rights need to be preserved. And for this reason, patients do not only need to understand how their data are used, but also they need to be part of the debate and have a voice in the discussion concerning the use of their own data. So digital health is rapidly evolving and changing, and so clarity is essential to boost the patient's trust. Patients need to feel empowered and have control over their own data. For example, patient-driven governance of the data should be in place, so that patients can be reassured of the safety of sharing data in new ways. So data and digital health also open the door to new ways of involvement for clinicians, industry, healthcare professionals, institutions, and of course patients in decision making process, in disease management. So to conclude, a data-driven cancer environment is already happening. We cannot and should not stop or slow down the process, but we must consider cancer patients as major stakeholders and help them build the trust in data sharing and management. Thank you.
Thank you, Antonella, for that very, very, very comprehensive and thoughtful response. And I think what has been very exciting over the last several years is to see patient organizations like ECPC, but it's certainly not alone, really play an integral part in shaping the dialogue and the discourse around how we use data. Sharif, I wanted to turn to you and ask you, Matt alluded to the use of artificial intelligence, of AI, and the importance of drawing insights from data. And one of the things that I recall from our previous discussions, and also with various members actually of the advisory group on this paper, was the excitement, but coupled with skepticism around the potential or the use of AI, and a note of caution about the importance of using AI appropriately and of putting the right frameworks in place so that we really can draw the appropriate insights out of data. And so again, I wanted to turn to you to ask, what are some of the key policy changes that you think are needed to get to that optimum use of AI, optimum development and optimal use of AI and of data insights more generally and data analytics?
Oh, brilliant. No, thanks for the question. And thanks so much to everybody at AllCan for the invitation to this really interesting session. I think before I answer the question, it's important to frame the context for this. And if you think about it, at the end of it, when we talk about patients and patient needing access to data, we forget at the heart of it is a human being who wants to do something. Right? Whether it's a human being who wants to live better, have a more fulfilling life, and overcome the challenge that is in front of them, or a human being who wants to look after the person in front of them, right? A clinician to do the right thing for the individual in front of them, or a human being that's responsible for a wider healthcare system and is trying to decide, how do I make optimal decisions about the limited resources I have to allocate effectively to improve the overarching outcomes for the individual, or human beings that are trying to research new types of innovations that are coming through the system so that they can come up with novel insights, novel ways of taking care of individuals. And that, I think, if we center the debate on that context, that at the heart of it is about people wanting to be empowered to do more than they can do today and achieve more, leveraging data, I think we get a sense of responsibility on what is then, how do we as both policymakers, industry, academia, all of that, do our part in making sure that those individuals get every bit of support that they need to be able to thrive. And then if I also then add a different dimension to it, if you look at the spectrum, because it's not just a single point in time where I'm not well and I want to see my data, or I want to make a decision about seeing a clinician. It's more than that. It's about understand the data needs, all the way from understanding the epidemiology of disease, all the way through to how do I even live better so I never have to fall into the challenge of needing care in any way, in the context of cancer care. So I think if we look at the breadth of what we mean by people leveraging data, and the breadth of what we mean by the instances in which data becomes really powerful and the place of AI, I think inevitably we come to the conclusion that having robust and appropriate regulatory standards that help to protect the rights of citizens to be able to build on data, and I use citizens in its fullest extent, becomes really, really important for us to be able to make the most of this. And with that, I think there are three main things I would say to policymakers operating in this space. Number one is around transparent and inclusive standards. It's not about we defining and then almost doing it to the individuals, whether that be patients or clinicians. How do we get to a position where the whole notion of how we use data and how we build AI has the people actually involved in it, involved in shaping it, involved in governing it, involved in deciding what happens around it, involved in shaping the future of it. So it's not a policy outside of the use, but policy within the use. And with that, a transparency and a liberation, so that there is no, decisions are being made outside of me, or I'm not aware of what's going on and I can't really do anything about it, if you like. So, just being able to amalgamate that and the quality and integrity of data sitting firmly within the context of a very transparent and inclusive mechanism for governance. And that brings me to the next second bit, which is, I think, a much more nuanced conversation. So there's a lot, I think there's space for policy, but there's also a lot of space for guidelines and a lot more nuanced, hyper-localized conversation. I can drop today from a flight in Sao Paulo and find out how to more effectively get from the airport to the hotel using data available to me than I can do how I take care of myself, if indeed I have any symptoms of cancer. And that's just remarkable, isn't it, when we think about it in those instances, that I can navigate the bus service better than I can do how to take care of myself in the context of cancer care. But those sort of, if you have the macro conversations at a global level, we lose the essence of what is it that a more hyper-localized, person-centered conversation can enable. So I guess my second point is, that nuanced, objective, localized conversation that brings that builds on the notion of the individual being at the center of it is absolutely vital in helping people not just see the value or the benefit of having data-based conversations or data-driven conversations, but the benefit of having data in empowered decisions that we make on the back of data. And then the last bit, I guess, in that context is frameworks. I think that helps to advance collaboration. At the end of the day, no single part of the ecosystem can solve this on its own. Every part of the ecosystem has its place, from innovators to innovators in its fullest extent, from technological innovators through to social innovators through to patient innovators, and enabling that, sort of using the framework of policy, enabling the convergence of these diverse stakeholders to be able to continuously drive collaboration and innovation in this space. Because do you know what? There's a lot we don't know. And we will only find out when we continue to talk in a very open and transparent manner together. So data integrity is critical, absolutely. Inclusiveness of data, representative data, absolutely critical. But I do think policymakers have a phenomenal role to play in driving transparency and inclusive through guidelines, nuanced and objective, hyper-localized conversations so they're relevant and impactful, and a framework that deepens collaboration so we continue to learn and get better in the process. Thank you.
Thank you so much again for fantastic insights, and again, crisp clarity seems to be the running theme throughout this session, which is wonderful. Roberta, I wanted to turn to you, and again, thank you so much for representing the WHO. I know you have a very busy schedule, and there's a lot going on, we can imagine, within that organization. We're really delighted to have you on board. And I wanted to ask you, sort of wearing two hats, I suppose, your WHO hat, but also as a practicing physician yourself, or at least a previous one. One of the things that actually we haven't talked about very much is the need to engage the healthcare professionals in getting to the data-driven system that we want. We heard from Christabel Saunders that data is everything, and data really drives decisions. And obviously every clinician, I think, wants to use data to drive better quality for their patients. But there is the issue of burden on already very tightly resourced and very, very busy healthcare professionals. There may be some cultural reluctance sometimes as well to embracing data as an integral part of clinical care and in the consulting room, as Neil was saying previously. So how can we incentivize healthcare professionals really in the appropriate collection and use of data in everyday care? And are there any lessons that can be learned from different country contexts potentially?
Thank you so much, Suzanne, for this opportunity. And as it has been pointed out by the previous interventions, we are all aware that robust information systems are essential for cancer control planning, monitoring, and performance in transforming data into health-related decision-makings. Development and implementation of incentive schemes for healthcare professionals involve a variety of measures. According to the WHO guidance on incentives for healthcare professionals, successful incentive packages are those that have to be tailored to the specific needs and preferences of the healthcare professionals. But at the same time, they must be realistic, context appropriate, equitable, and transparent. These incentives might include both financial and non-financial interventions. As examples, additional payments or bonuses, or also the non-financial would include work autonomy, flexible working schedules, training and education, as well as recognition of work. And these non-financial incentives are very relevant, particularly in the field of low and middle income countries, or for those organizations that have limited fundings to provide financial rewards. Incentives can be seen as a tool for policymakers and managers to contribute to retain the healthcare professionals, particularly in the case of data managers that are skilled and trained for the purpose of improving health information systems. So this requires a multi-sectorial and multidisciplinary approach. All healthcare providers have to contribute according to their given competencies, advocating both at patient and facility levels, as well as it has been mentioned, to involve the legislative agendas, which is important for sustainability. So for the second part, regarding some examples, I would like to share some of our experience. As you mentioned, both are pediatric oncologists involved in different collaboration networks at regional level in Central America as part of the Association of Pediatric Oncologists of Central America, the AllCan group. I can cite examples of regional networks to develop health information systems. With support from international global partners such as St. Jude Children's Research Hospital and Munster's International School of Pediatric Oncology, to develop a pediatric oncology network database that was created at the beginning as a registry and then extended to the function of support protocol-based care to improve and standardize the quality of care for children with cancer in the region, contributing as well as to monitor, but also to identify areas to prioritize. In many low and middle income countries, a big problem that impacts negatively in the outcomes for children with cancer is abandonment or early interruption of therapy. So this is a very important limitation or barrier to tackle. So by having access to relevant information provided by this network, a therapy interruption can be addressed by designing priority actions such as socioeconomic support provided to the families in order to guarantee the compliance with the treatment. And this intervention proved to be effective in reducing the rate of abandonment or early interruption of therapy that was as high as 30% in most of the Central American countries in the first years, as low as to less than 5% after the interventions were implemented. So technical and economic support from international partners contributes importantly to career progression in data managing in this regional network by building and strengthening competencies and skills. And this kind of model that has been successful is now being taken into consideration as part of the activities that the WHO Global Initiative for Childhood Cancer is carrying out to implement to achieve the goal of increasing childhood cancer survival in at least 60% worldwide by 2030. So this model of collaboration, it's now also extending to improving health systems information. And our colleagues from the International Agency of Research, IARC, are joining efforts with St. Jude Children's Research Hospital, working in collaboration with regional and international networks of professionals, taking part in the Global Initiative for Childhood Cancer Registry Development. The main goal of this collaboration is to improve the quality and availability of data, particularly in low and middle income country settings, through the implementation of what has been said, it's necessary international cancer registration principles and standards. And some of the priority interventions to achieve this goal involve training and knowledge transfer, building competencies and skills, cancer control and research, and facilitating collaboration between partners and different stakeholders. This joint collaboration will contribute to strengthen the local capacity for cancer registration, providing a platform to contribute to member states' capacity to scale up the delivery of care for children with cancer around the world. And it would also improve access to high-quality information in childhood cancer burden and survival. Thank you.
Thank you very much, Roberta. And there was actually a comment on the chat addressed to you, two comments. One saying that the initiative you're mentioning and the networks have been incredibly impactful and led to a lot of really exciting publications in partnership with the IARC. But there was a query about whether you were actually suggesting financial incentives to healthcare providers to collect data. With the suggestion that in low middle income countries particularly, it could be perceived as a bribe. I was wondering if you had any comments on that.
Thank you very much for this important comment. As I mentioned, non-financial incentives as well are very valuable. The main problem in low and middle income countries, knowing that you have sometimes very low salaries, and this could be also a problem to retain the professionals that have already been trained and skilled, and they will move on to pursue other jobs in, for instance, private institutions where they are more compatible incentives for them. So this is, it's trying to find the balance, because it's very relevant to keep this already trained professionals. So as we have seen from the experience of the All.Can network, key people were identified to be trained as data managers, and they were provided with specific training to scale up their capacities as well. And through international collaborations with written agreements between the local ministries of health and the local facilities, this support was provided, as part of the institution, seen as an institutional effort in collaboration with international partners. But it was a very important intervention because most, as I mentioned, in low and middle income countries, health systems do not have the capacity to support many of these workforce capacities that are really needed for childhood cancer programs to be effective. So multi-sectorial involvement is very relevant, as I mentioned. And as part of the main objectives of the global initiative, we have outlined 4 pillars and enablers that are needed to strengthen health systems' capacity to deliver quality of care for children with cancer. And among these, one of the main important enablers, it's also leverage financing and advocacy. So joining together the efforts of multi-stakeholders, it's really relevant to sustain effective cancer programs, particularly in the setting of low and middle income countries. Thank you.
Thank you so much. And I wanted to say, I realize it's a controversial topic, but there is actually an example in the data report of an initiative in France where physicians were paid to collect outcomes data, but they were paid regardless of the outcomes achieved, which I think is a very important caveat, obviously, because otherwise you're incentivating the data collection, and it's not a blaming and shaming activity. Where time is sadly running out for this session, and I wanted to conclude. We've had a couple of questions from the audience, which really speak to whom should we involve in trying to find solutions to the issues that we've been discussing. And so I wanted to just conclude, and sorry for springing this question on you, but I wanted to ask each of you very briefly if you can talk about how do we really get the right people around the table to drive the change that is needed, or is that happening already? And I'll give you another alternative. Is there one sort of prominent example in your mind of where this multi-stakeholder approach to really trying to address the complexity of what is needed to achieve the potential of data in cancer care, where that's already being achieved? So I'm going to go with the order of speakers that we started with. Deepak, could I ask you, do you have one example that springs to mind?
Not one example. I think I'll just quickly say that I know time is against us. Multi-stakeholder engagement is something that I've been very privileged to be part of over the last few years. There is no stakeholder I've yet thought of who shouldn't be coming around the group. So it really is a massive group. Care, research, patient, public, obviously, decision makers of different kinds, regulators. It's a long list of people who should be around the table. But importantly, when you invite them, they are really passionate and interested, and they want to learn from each other. I have not yet come across a negativity saying, no, we need our own protected space. They realize they don't know the whole picture, and they learn from each other with great delight.
Thank you. Antonella?
Well, as everyone said, and I also mentioned, we needed this multi-stakeholder approach. I think that very broadly in Europe, a multi-stakeholder approach has been put forward by the European Commission with the GDPR process, the directive, and the implementation. Of course, it is not optimum, but it's on its way. And then I can also mention that on several research you funded projects, like the Horizon 2020 or some IMI projects using big data to support cancer care. There is a multi-stakeholder approach. I must say that we are working together with academia, with policymakers, even sometimes on the consent form. And for instance, even the consent form, which could be seen as a standardized process on each of these projects, we agree on together on the design and how the consent form should be presented and submitted to patients. So I think that step by step we can really achieve and implement this multi-stakeholder involvement.
Thank you. Sharif, can I turn to you?
So a really good example would be the Industrial Strategy Challenge Fund, I think, that happened in the UK. Now, it's still in the process, so we'll see, the outcomes as it comes through. But a couple of things strike me with that model, where you have the National Health Service as the entity that is responsible for patient care delivery, helping to frame the clinical challenge that needs to be solved, but grounded in practical day-to-day reality for the needs of patient. Alongside academic partners who are in imagining the future of care and constantly innovating, helping to make sure that we're not just asking mundane questions, but we're asking questions that are foundational, fundamental, and deeply insightful, alongside big industrial partners who are there to help to bring the muscle of industry to help to frame some of those challenges and the mechanism for scalability, so that when it's solved once, it can be scaled up relatively easily across the organization, alongside startups and big innovators in AI and all of that, who are much more nimble in being able to translate a problem into a definable practical solution, but knowing that they're part of a wider consortium that affords them a mechanism for scaling up at lower cost than they would do on their own, alongside patient associations who are there to make sure that the voice of the patients is central to defining both the problem, but also imagining the kind of solutions and the mechanism for scalability, all backed by NHS England and the government, etc., who are there to make sure that, I guess, everything that is built is firmly anchored into the future of care delivery, both locally as well as internationally, as the UK looks to do more in advancing care. Now that it's still in its process, so I won't necessarily say it's a huge success yet. Time will tell, but it provides very powerful evidence of how you take complicated issue around cancer care, complicated subject innovation in AI, and driving a multi-stakeholder conversations in a way that's really impactful.
What a great example. Thank you. Roberta, I know you've already spoken about a multi-sectoral approach, but
yes, I think I will just compliment and agree with fellow participants here. And I think that I can cite that the best example is the Global Initiative for Childhood Cancer. As you have seen, our framework of work and how to implement and to progress the quality of care for children with cancer worldwide is based on this effective partnerships and networks, both at regional and national and global levels, where all come together, as it's mentioned, the academies, the ministries of health authority, both state and non-state actors, or joining efforts to strengthen the capacities of member states to improve the quality and the delivery of services for cancer. So I think this is the best example that I can share with you today. Thank you.
Great, thank you so much. We have run out of time, unfortunately, but I wanted to very sincerely thank each of you on the panel for your really fantastic contributions. Thank the audience as well for your questions, and thank Matt, who's not on the screen at the moment, but for his really great starting presentation. And Alex, I think I'm handing back over to you, if I'm not mistaken.
Yes, thank you, Suzanne, and Matt, and all the panelists really today for an excellent discussion. And congratulations to all who have contributed to bringing the data paper to life. As you said, it's been 2 years of work with which, it's not an easy feat to put into one session, but it's a great start. And I think I'm personally looking forward to further collaboration across disciplines. And capturing political will for better use of data to improve cancer care. So now, in closing, I would like to invite Dr. Matti Apro to share some final remarks and reflections from today. And Matti, it doesn't need an introduction, but I still will give one. He's a medical oncologist, my fellow board member of AllCan International, and president of European Cancer Organization, and director at the Genolier Cancer Center in Switzerland. And Matti was part of the AllCan initiative from its inception as well. And I couldn't think of a better person to conclude AllCan Global Summit. So Matti, over to you.
Thank you very much, Alex, for your very kind words and reminding people that I'm old enough to have been here even before AllCan started, because the European School of Oncology had a meeting about the question of waste and inefficiency long before this AllCan initiative started. And I remember when Suzanne approached me, as she was the one driving this, and now it has been taken over by the new AllCan board. I kind of remember, oh yes, we did something around this a few years ago. And it was already based on some of the observations that in our health systems, and I would like to go beyond oncology. It's true for the whole health system. It's true for many other items also in this world, that we are not efficient. We use available resources in the wrong way. And unfortunately, in our setting of healthcare, this harms patients. And what we discuss here is a way to do better with available means, liberating some of the means which were misused in order to use them better, in order to develop some further treatments for the patients, improved surgical approaches, improved radiation oncology approaches, and improved medical oncology approaches. And I think what was very nicely said by several speakers and at the introduction is that this is not about cost reduction. This is about using what we have in a better way and also adopting new evidence-based methods to move forward. There's no doubt that looking at efficiency, you can have different perspectives. You can have perspectives that sometimes do not talk to each other. But let's remember that we are here speaking about patients, and it was highlighted and clear that the patient-reported outcomes are very important. My comment there is, however, as a clinician on daily practice, that it's not very easy to ask the right questions to the patients. The questionnaires are sometimes misunderstood, difficult for the patients to understand. Nurses very often help them, but is this really the right way to go? It's extremely complex. So what you ask, how you ask it, and how you report, the patient reports back the answer and you interpret it, is quite complex. And this was also very nicely highlighted by several of the speakers. If we speak of efficiency, we also alluded to the fact that there are issues in, let's stay in Europe, different areas in Europe, within countries, different regions have different ways of tackling these questions. And we should be very careful not to say that everyone needs to have everything, which seems to be a trend that I've heard in various meetings at the European Union level, that no, I strongly believe that we need a European health initiative. And this is a word that was put forward by Ursula von der Leyen herself. COVID should have taught us that there is no border for health. There should be no regional border, there should be no national border. Health has to become an initiative for every single citizen of Europe and countries which are unfortunately outside of Europe for one reason or another, like the United Kingdom and Switzerland, for example, where I live and work. Our silo thinking should also be put aside. I said we are speaking of cancer, yes, but let's look also at inefficiencies in other areas, because we can learn from solutions that others might have brought. And one important point that we should have mentioned, and I'm happy to have at least something that I can mention original, is the importance of the work of the general practitioners, of those that provide the primary care before cancer, often help during the cancer, and certainly after the cancer treatment, provided it has been successful. The quality of the data was highlighted. I made already an allusion to that about prompts. There's no doubt that there's an old saying, thrash in, thrash out. You can apply the best possible statistics, artificial intelligence methods. If what has been put in the system is not of high quality, you will never get an answer. So let's not forget that. We ended by a wonderful presentation about the pediatric setting. Then here, I of course, would like to say that we should not forget our elderly patients that are really needing a lot of help from many perspectives, highlighted unfortunately also by the COVID crisis. So with this, I would like to conclude and thank everyone. Thank especially those that joined us from many areas throughout the world. It was wonderful to see people from Argentina, Brazil, all around the Mediterranean, and speakers coming from many areas, like our dear friend from Australia. So Christobel, thank you for being with us. I wonder what time it is for you right now. It must be beyond midnight. And the work that has been put on by all the All.Can members in different countries throughout the world has been paramount for everything that All.Can has been able to achieve in the past 4 years, and we count on you in the next few years. So thank you very much to all.